Two treatments used every day in ICUs around the world may not be helping our patients at all, and one of them may actually be causing harm. At the same time, a therapy many of us use to correct severe metabolic acidosis just failed a major randomized trial. And finally, a growing number of patients with serious fungal lung infections do not fit the traditional definition of immunocompromised. This week, we look at two major randomized trials published in the New England Journal of Medicine and a timely review from CHEST that challenges how we think about fungal disease in the modern ICU and pulmonary clinic. I'm Dr. Aladdin Sagar, and this is This Week in Pulmonary and Critical Care Medicine. Walk through almost any ICU and you will see it. A mechanically ventilated patient develops thick secretions. The respiratory therapist recommends hypertonic saline. The physician adds a mucoactive agent. The logic seems straightforward. Thin secretions, improve clearance, liberate patients from the ventilator sooner. But has that assumption ever actually been proven? That question led to the March trial, published in the New England Journal of Medicine in June 2026. Investigators enrolled nearly 2,000 mechanically ventilated patients with acute respiratory failure and difficult-to-clear secretions across 71 hospitals in the United Kingdom. Participants were randomized in a factorial design to receive carbocisteine, nebulized hypertonic saline, both therapies, or usual care alone. The primary outcome was duration of mechanical ventilation. This is where things became interesting. Despite widespread use, neither intervention improved the outcome that clinicians actually care about. Patients receiving carbocisteine had a median ventilation duration of approximately 186 hours, compared with 173 hours among those not receiving carbocisteine. The adjusted hazard ratio was 0.96, no benefit. Hypertonic saline performed no better. Median ventilation duration was approximately 185 hours versus 174 hours without hypertonic saline. Adjusted hazard ratio of 1, essentially identical outcomes. Now, a neutral trial is not necessarily a negative trial. Sometimes an intervention simply doesn't work. But this study went further. Carbocisteine was associated with significantly more clinically important upper gastrointestinal bleeding, 1.4% versus 0.2%. Hypertonic saline was associated with significantly more bronchoconstriction, requiring bronchodilator therapy. More concerning, hypoxemia during nebulization occurred more than 10 times as frequently in patients receiving hypertonic saline. Think about that. No reduction in ventilation duration, no meaningful signal toward benefit, yet measurable adverse events. The physiological rationale remains attractive. Hypertonic saline increases airway surface hydration. Carbocisteine alters mucus rheology. Both mechanisms make intuitive sense. But patients do not come to the ICU because they have thick mucus. They come because they have respiratory failure. And improving a physiological parameter does not automatically improve a clinical outcome. We've seen this story before. Better oxygenation does not always improve survival. Better laboratory values do not always improve outcomes. And apparently, thinner secretions do not necessarily shorten ventilation. There are limitations. The trial was open label. Difficult to clear secretions was based on clinician judgment rather than a standardized definition. And it remains possible that highly selected subgroups could still benefit. But with nearly 2,000 patients enrolled, the overall signal is difficult to ignore. In practice, this means routine use of carbocisteine or hypertonic saline in mechanically ventilated adults with acute respiratory failure should probably be reconsidered. If you are reaching for these therapies, the burden of proof has shifted. The assumption can no longer be that they help. Now let's move to a question that has divided intensivists for decades. Your patient is in septic shock. The pH is 7.21. Vasopressors are escalating. The bicarbonate level is falling. Do you give sodium bicarbonate? Most of us have faced that decision. The physiology appears compelling. Acidemia impairs myocardial contractility. It reduces responsiveness to catecholamines. It is associated with acute kidney injury and mortality. Correcting the pH should help, at least in theory. The SODa-BIC trial, published in the New England Journal of Medicine in June 2026, tested that assumption directly. Investigators enrolled 500 critically ill adults across 55 ICUs in 7 countries. All patients had metabolic acidosis with a pH below 7.30 and were receiving vasopressors. Participants were randomized to receive either protocolized sodium bicarbonate infusion or placebo. Importantly, this was a blinded trial. That matters because previous bicarbonate studies suggested reductions in renal replacement therapy, but clinicians knew who received bicarbonate. Knowledge of treatment assignment could influence the decision to start dialysis. The primary outcome was a major adverse kidney event at 30 days, a composite of death, renal replacement therapy, or persistent renal dysfunction, and the result was remarkably clear. 40.2% of patients receiving bicarbonate experienced the primary outcome compared with 39.4% in the placebo group. No significant difference. The adjusted absolute difference was 1.2 percentage points. Mortality was also unchanged. 30-day in-hospital mortality was 25.4% with bicarbonate and 24.0% with placebo. Again, no significant difference. Renal replacement therapy occurred somewhat less frequently in the bicarbonate group, 16.8% versus 20.9%, but the confidence intervals crossed zero and the difference was not statistically significant. This is where the study becomes difficult to ignore. Bicarbonate successfully corrected physiology. The intervention improved acid-base status. Yet correcting the number did not improve the patient-centered outcome. That distinction matters. Critical care has a long history of therapies that improve physiology without improving outcomes. The pH changed. The kidney outcomes did not. The mortality outcomes did not. The patient trajectory did not. There are limitations. The enrolled population had a median pH of approximately 7.26, so these findings may not apply to patients with extreme acidemia. Patients with diabetic ketoacidosis and major bicarbonate losses were excluded, and clinicians could still administer open-label bicarbonate after completion of the study protocol if they felt it was necessary. Nevertheless, this is the highest quality evidence we have to date in shock-associated metabolic acidosis. In practice, this means bicarbonate should not be viewed as a routine kidney protective therapy in patients with metabolic acidosis and shock. Correcting the pH may occasionally be necessary, but clinicians should not assume that normalization of acid-base physiology will translate into better renal outcomes or survival.
Let me teach something here.
A patient develops persistent pulmonary infiltrates. Antibiotics fail, cultures remain negative, bronchoscopy is unrevealing. The patient has no cancer, no transplant history, no neutropenia, no immunosuppressive therapy. Most clinicians quietly move fungal infection down the differential, and that may be the first mistake. A comprehensive review published in Chest this month examines an increasingly important phenomenon: pulmonary fungal infections occurring in patients we traditionally label as immunocompetent. The central message is not that fungal disease is common. The message is that our definition of risk has changed. Think about how we traditionally learned fungal infections: Aspergillus in neutropenia, Cryptococcus in advanced immunosuppression, histoplasmosis after classic endemic exposure. The framework is familiar, but modern medicine has introduced new risk factors that do not fit those categories. severe influenza, COVID-19, prolonged mechanical ventilation, critical illness itself, underlying COPD, structural lung disease, liver cirrhosis, environmental changes affecting fungal distribution. The number hasn't changed. The meaning of the number has. A normal neutrophil count no longer excludes meaningful fungal disease, and that is the key physiological principle. Host defense is more complex than whether someone is immunocompromised on paper. Critical illness produces immune dysfunction. Viral pneumonia disrupts epithelial barriers. Structural lung disease alters local defense mechanisms. Together, these changes can create an opportunity for invasive fungal infection, even when traditional risk factors are absent. The review highlights another common misconception. Many clinicians place significant weight on serum fungal biomarkers, but serum galactomannan performs substantially less well in non-neutropenic patients. Beta-D-glucan performance varies considerably depending on the pathogen and clinical context. A negative blood test may therefore be falsely reassuring. Think about the patient with persistent infiltrates, repeated antibiotic exposure, and progressive respiratory decline. If fungal disease is not being considered, the diagnosis may never be made. And even when it is considered, definitive diagnosis frequently requires invasive sampling, bronchoscopy, BAL, tissue acquisition. Cultures alone are often slow and insensitive. This review also provides an excellent reminder that imaging patterns are not always classic. Invasive aspergillosis in non-neutropenic hosts often presents with airway-centered disease, tree and bud opacities, centrolobular nodules, and peribronchial consolidation, rather than the textbook findings many of us learned during training. That distinction matters because pattern recognition often determines whether fungal disease enters the differential diagnosis at all. The limitation of this article is that it is a narrative review rather than primary research. It cannot establish incidence rates or quantify risk, but that is not its purpose. Its value lies in updating our mental model. In practice, this means fungal infection should remain on the differential whenever pulmonary disease behaves unexpectedly, fails to respond to conventional therapy, or occurs in the setting of modern risk factors, such as severe viral infection, prolonged ICU exposure, structural lung disease, or unexplained respiratory deterioration. And perhaps the most important teaching point is this: immunocompetent does not mean immune to fungal disease. That is often where real clinical understanding begins.
3 papers this week, 3 very different clinical questions, but a common lesson. We often assume that a physiologically sensible intervention must improve outcomes. Sometimes it does, sometimes it doesn't. Hypertonic saline and carbocisteine seemed logical. Neither shortened mechanical ventilation, and both introduced harm. Sodium bicarbonate corrected acidemia, yet correction of the physiology did not improve major kidney outcomes. And in pulmonary fungal disease, familiar assumptions about who is at risk are becoming increasingly unreliable. The challenge in modern pulmonary and critical care medicine is not simply knowing more evidence. It is recognizing when evidence forces us to rethink what we thought we already knew. If one of these studies changes how you approach a patient this week, share this episode with a colleague, and let me know which finding you found most surprising. I'm Dr. Aladdin Sagar. Until next week.